decision shapes recovery. All Things Neuro and Neuro 360 is a specialized neurocare organization focused on the diagnosis, treatment, and rehabilitation of traumatic brain injuries and concussions. A multidisciplinary team works together to deliver coordinated care, guided by advanced diagnostics. All Things Neuro and Neuro 360.
Anyway, well, let's get to it because there's a lot of information and the technical stuff doesn't really matter. But I know Jen talked about case studies. Actually, I'm going to do studies. I've treated thousands of patients with brain injury and serious injuries, and those would be more or less case studies talking about those cases. But today I'm going to talk about some of the top cases or top studies are out there, and even recent ones that are important for you to know for someone who deals with brain injury. And it's also important to know what to do with it. So across the country, I've taught seminars on about how to educate adjusters, defense attorneys, trial jurors, other doctors on traumatic brain injury, because it is something where the old school paradigm is completely different than the new paradigm. So today we're going to talk about some of the top studies that you need to know as an attorney or doctor or a payer for brain injuries, and then how to use them. So how to use them is important because, setting education letters to the adjusters is important. Helping them set the reserves right to understand this is a brain injury and this is something that needs to be taken seriously. So hopefully these studies you could use in your practice, and I'm going to provide all these to Jen so she could actually distribute them if anyone wants them. But there's a couple important things that have happened in 2025 that are really essential to the aspect of treating patients with brain injury and advocating for them. Number one is that Medicare has announced this year, starting 2025, they now classify brain injury as the beginning of a chronic health condition. So if you have any brain injury, that's the beginning of a chronic health condition. It doesn't matter if it's mild, moderate, or severe at the entry level. In fact, they're doing away with those terms, that there's no longer the term mild, moderate, and severe. Presently, 1 in 60 people are living in the United States with a permanent brain-related disability. And this is essential because of the fact that this is called a silent epidemic, because a lot of people live with these problems and they're in silent because you can't really see them. It's not like a broken bone, but they live with these problems and they change every aspect of their life. They make life more difficult. So it's important to realize that this is an evolving field. Studies are coming out literally every week, every day that are essential for you to know, but also to help realize that this is a more serious problem than we thought. And this is interesting because this is straight from the AMA guide. So I've been doing impairment rating since 2005. It's something being kept up with on a regular basis. And in a study in 2011 said that in 1950, the science for medicine would double every 50 years. In 1980, it would double every 7 years. In 2010, it would double every 3.5 years. And by 2020, it was projected every 73 days, the science would double, meaning that if a doctor's been in practice for 25 years, the things he learned in school is pretty much outdated to what the science shows today. And this is true with brain injury as well. You see a lot of people say, "Oh, it's a brain injury. They're better. They're not incapacitated." Severe brain injury is typically someone that is in a coma. Moderate brain injuries, they're incapacitated. Mild brain injury affects every aspect of life and makes life more difficult. So it is important to realize that these injuries are very serious, but also the science is outdated for a lot of reviewers, a lot of attorneys, a lot of insurance companies are using. And, again, counseling and talking and educating providers throughout the country. I see a lot, they say, "Chris, I see a lot of injury patients, even sports injuries. I see a lot of injury patients, but I don't see a lot of brain injuries." And I'm like, well, you may not see them, but they see you. It's important to be aware of some of the signs and symptoms of brain injury so you could spot these patients. Because the Brain Injury Association of America says that there's a brain injury every 9 seconds. So it's important to be aware of the statistics and the findings so you can help to spot patients who have brain injury. And what's the frequency? Well, it's a lot more common than we think. In fact, estimates, or this study here on the bottom, and all the papers I cite here, I could give references to, about 25% of patients in moderate to severe impact collisions are going to have brain injuries. 46% of these, the 53%, still have functional problems for up to 1 year after the wreck. So 25% of all the cases that are considered mild, moderate, and severe impact would have brain injury. Now, it's not a simple rear-end collision. We're going to go over these stats in a little while, but typically rollover collisions, T-bone collisions, multiple impact collisions, airbag collisions. So it would have to be a significant acceleration, deceleration to the brain to cause a brain injury. But this is a study that was done of people in motor vehicle collisions. 25% of these have brain injuries. It's also important to recognize that PTSD and anxiety are very common. So about 25 to 30% of patients in motor vehicle collisions have PTSD or anxiety, and they normally don't have access to care. Sometimes this could lead into other problems such as chronic pain and other issues, but it's important to recognize that mental health is very important to address after a collision as well. And there's lots of studies out there, and 25% of people in all collisions are going to have some type of PTSD or anxiety. So these are some of the common things that I get, as far as questions about, that they didn't report a collision, or maybe there's a gap in care. And so brain injuries have been a mystery for many years. They've been missed. And so studies show that 50% of people who have brain injuries, it's not even reported. I didn't think it was anything serious. I didn't even know I had a brain injury. In fact, Brett Farr, when he was first getting involved with brain injury, they asked him how many concussions he thought he had. And he said, well, I could only remember one time when I was knocked unconscious. But then they explained what actually a concussion was. And he said, wow, he said, knowing that, I probably had about 1,000 concussions. And so it's important to realize you don't have to lose consciousness to have a concussion, but also most are not reported because they don't even think that they have a concussion. Also, a lot of times too, we just say, hey, did you lose consciousness? And in many cases, patients will say, I don't think I think I blacked out, but I don't think I lost consciousness. And so it's important to realize that they're probably not even going to know if they lose consciousness or not, because sometimes they think they just black out. But 56 to 65% of mild traumatic brain injury cases are missed at the ER. In fact, a recent study at Emory University of 32,000 people found that they missed concussion 65% of the time. And even if they do recognize they have a brain injury, go to the ER, 52% don't have follow-up care. And that's why there's a need for access to care, early diagnosis, and studies show the earlier the diagnosis, the better the treatment. The earlier we get the patient to go from a primary injury and prevent secondary injury, the better likely they're going to have less problems as they get older. So it is really important to get early access to care for mental health care and for brain injury. This is that study I was telling you about in the Journal of the American Journal of Emergency Medicine. It was Emory University, and 38,000 patients they studied, and they only found brain injury in 35% of the cases. So this is an alarming statistic. Emory is a great teaching university and a great university, and for them to miss 65% of brain injury cases is alarming, but that makes you wonder too, how many are missed in traditional settings? And I've been in a lot of cases where even orthopedists, neurologists, they don't really focus on this. So a lot of times they'll actually miss brain injury. Many times they'll say, well, they didn't lose consciousness. They didn't have a brain injury because they didn't lose consciousness. Fewer than 10% of concussions lose consciousness. And in older patients, it's actually less likely they're going to lose consciousness. So when they lose consciousness, basically the brain shuts down to restart again. And when that happens, that actually is a protective mechanism. As patients get older, the odds of losing consciousness go down. So it is important to realize that losing consciousness is actually a protective mechanism, but also is not in all cases. 90% of patients who have concussion don't lose consciousness. And the ICD-9 codes represent that. So they actually have a TBI diagnosis with traumatic brain injury without loss of consciousness. So sometimes there will be pushback saying they didn't lose consciousness, when in reality, most patients don't lose consciousness. The CT scan was negative or MRI was negative. Well, this is just looking for a bleed. 90% of these patients are negative. So this is a huge problem where they're over radiating people with CT scans. And they say, well, look, most patients don't have positive findings anyway from CT scans, because the only thing CT is looking for is a bleed. Are you going to die? If you hurt your knee and you go get a CT scan of your knee and they say, well, good thing, we did a CT scan, there's no bleeding in the knee. Well, I didn't think there was going to be bleeding anyway. So CT is great if you have stroke, if you're having subdural hematomas, things like that, as a screening tool. But in 90% of these cases that have brain injury, it's going to be negative. Glasgow Coma Scale. This is something where this is just a scale saying that they have, are they in a state of coma? And it was originally started in the 70s, and it was never meant to be a long-term predictor of patient care or outcomes. And it's usually meant to be just within the first entry level. So Glasgow Coma Scale of 15, A lot of people have continued problems of it. In fact, in this study, they found that 2.5% had bleeds, 1.4% had fractures. So Glasgow Coma Scale is a great entry-level tool to help to see if someone's going to be dying or not, or have severe brain bleeds. But long-term, it's not a good clinical indicator. Now, there is something called the Glasgow Coma Extended Scale, which after 4 weeks, you could do the Glasgow Coma Extended Scale and show if there's continued deficits. But Glasgow Coma is only meant for the first 4 weeks. This is a study in the Journal of the American Medical Association in 2022. Mild traumatic brain injuries with negative CT, normal Glasgow Coma Scale did not recover 2 weeks and 6 months post a motor vehicle collision. And this is a study of almost 1,000 people. So even if they have a negative CT scan, normal Glasgow coma, they still have continued symptoms for quite a long time. So what is a brain injury? Well, the Traumatic Brain Injury Association of America, the CDC, and the military, God bless our veterans, but unfortunately they have a high rate of traumatic brain injury, and we do DBQ exams, disability exams, nexus letters for them. And so the VA has actually done a great job in the last 5 years of awareness about brain injury and different pathways to help treat it. But a brain injury is an alteration in brain function or other evidence of brain pathology caused by an external force. So a brain injury is an alteration of brain function or other evidence of brain pathology caused by an external force. And this is an important definition to know. It doesn't say you have to hit your head. It doesn't say that, there has to be a brain bleed. It's an alteration of brain function. When we're looking for a brain bleed, we're looking for a structural deficit. We're looking for a fracture. That's a structural deficit. This talks about the brain, how it's functioning. That's why functional tests are essential to help determine how the brain is doing. And this is a landmark paper that was 2010, I believe. And it's something that led to the CDC and the government classifying brain injury this year as the beginning of a chronic disease. Traumatic brain injury is a disease process, not an event. The purpose of this article is to discourage the classification of brain injury as the beginning of an ongoing, perhaps lifelong process that affect multiple systems that have disease causative and accelerated process. Brain injury should be managed as a chronic disease and defined as such by healthcare and insurance providers. So this is the beginning of a degenerative or ongoing process in most cases, sometimes far removed. So we're going to talk even today about epilepsy, and your normal rate of brain function or epilepsy doesn't normalize until 10 to 15 years after the trauma. So brain injury takes a while to develop, and that's why sometimes it's not been associated with it just because of the fact that they thought, well, it's a year afterwards. But in reality, that's actually the clinical time it takes for these pathologies to show. But this is a landmark paper. They used it for Medicare. They used it for government programs to talk about how brain injury is the beginning of a chronic disease process, not an event that typically gets better. A broken brain is different than a broken bone. And this is a slide that I use on a regular basis. A broken bone, when you break it, it actually is going to heal very, very well. A broken brain leads to secondary changes in the brain, such as reduced blood flow, mitochondrial dysfunction, oligodendrocyte dysfunction, blood-brain barrier. There's a whole gamut of things that cause neuroinflammation. And so it leads to secondary problems. As a treating provider, treating patients for brain injury, having family members that have brain injury, our job is to stop the primary injury from cascading into a secondary brain injury. So if we could stop that, we could reduce the long-term nature of these injuries. But in general, a broken bone is going to heal. A broken brain gets worse over time, deteriorates, but you may not see for months or even years later the progression of it. It's interesting because in collisions, people say, oh, good thing you don't have a broken bone. I would much rather a broken bone than a broken brain. So this is another paper from the same, another diagram from the same paper. The secondary brain injury is a series of changes that occur in the brain hours or days after the initial or primary injury. These changes can be cellular, chemical, tissue, blood vessel related, and can lead to further damage in the brain. And this is a very, very important thing to realize because people talk about, oh, there's nothing broken, there's no bleeds, but that's for the primary injury. It's a secondary injury that we have to focus on. In fact, I'm writing a book called TBI, A New Paradigm, talking about this, how this is a process that's important, not just for brain injury patients, but also for dementia, Alzheimer's, a lot of other disease processes that we're seeing in our society. And this is a presentation I do. I'm not going to go over it because it would take hours, but this is actually one I've done last year on the entire big picture of traumatic brain injury. We have the acute stage traumatic brain injury. Then it's classified after 3 months into something called persistent post-concussive syndrome. And over time, it leads to neurodegenerative disorders. So at the beginning, we'll have mild, moderate, and severe. And as you can see, there's different things, tissue damage that could occur into the brain. And then next, you would have persistent post-concussive symptoms. And that's typically when a brain injury lasts more than 3 months. And that's something that you see a whole cascade of events: negative neuroplasticity, blood flow dysregulation, glial cell dysfunction. So there's a whole cascade of secondary events that gets set off. What I like to use the example of is rust. So if someone hits your car and they knock the paint off of it, what's going to happen over time? It's going to rust. You're not going to see that rust initially. It'll take months, if not years, for that to really show. And the same thing with a brain injury. You have the primary injury, then the secondary effects of it. Okay, but I put this here just to show the big picture view that we have a traumatic brain injury, the primary stage. The secondary stage is called persistent post-concussive symptoms, and that is something that is typically after 3 months post-injury. And then later on, that leads into neurodegenerative conditions. Could dementia, stroke, seizures, CTE, suicide, chronic pain, all sorts of other problems they're finding, even endocrine problems. So we're going to go over those studies in a little while. I put this there just to get a big picture view. Now, this was a very landmark study that was published by the American Academy of Rehabilitative Medicine. And it took them 6 years to put together as far as how to diagnose someone with a brain injury and what is the diagnosis. And I do seminars for providers to help train them in screening for brain injury, but also it's important to realize for attorneys' offices as well, because a lot of times they're the ones talking to clients on a regular basis. So it is important to realize that there's some screening tools you could use to help screen for patients with brain injury. And I'm going to share those with Jen that she could get to the group. But we use this guideline because this is the most peer-reviewed guideline out there about diagnosing patients with brain injury. Again, there could be hours just of this seminar on this topic, but it is something to be aware that this is an important study to put in your arsenal. It's peer-reviewed, took 6 years to put together, and it's one of the benchmarks for diagnosing patients with traumatic brain injury. In that paper, they talk about mechanism of injury. And it's important to realize what are the mechanisms. So you want to have truck collisions, rollover collisions, T-bone collisions, pedestrian collisions, airbag collisions, double impact collisions, and domestic violence. And we're going to go over in a little while some of the statistics on these, but this causes long-term problems in patients because of the mechanism of injury. And we're going to hit that today, a little bit about what are the mechanisms of injuries that cause more long-term problems. If it's a simple rear-end collision, it's most likely not going to be a brain injury. Could be PTSD, it could be ligament damage. I just did a case yesterday, and that was the case where it was a very low impact collision and there really was no brain injury. It was actually upper cervical ligament damage. So it's important to get the diagnosis right, because that's going to make your job as attorneys better down the road. I always like to say a good diagnosis is the first step to a good treatment, and it's never the wrong time to make the correct diagnosis. If you're going to court or trial with these cases, it's important to really know, is the diagnosis accurate? But look for these. These are some of the big screening tools you should be looking for: truck collision, rollover collision, T-bone, airbag, pedestrian collisions, falls, domestic violence. But pedestrian collisions, particularly, and motorcycle collisions, I see a lot of. And pretty much all cases, once you dive into these, if there's been significant impact, you're going to find some brain injury. It's just a lot of times they may not think it's related. So this was a great study, and again, I put all the sites here. We're talking about the brain and how it functions to different traumas. And we're fine thinking about combat sports. We're thinking football, brain injury, but this was a very interesting study because what they did is they found that pedestrian collisions, motorcycle collisions, falls, motor vehicle accidents, those collisions, the speed is a lot faster than could happen with a boxer or a football player. The acceleration and the speed that this happens is important for the brain because the brain has something called viscoelastic properties, meaning that if you take, like, for instance, Play-Doh and you go very slowly, it's going to stretch over time. If you do it very quickly or shearing motion, it actually tears. So the axons have something called viscoelastic properties. And this was something somebody asked me one time, Chris, these boxers or football players, you see repeat head injuries, but yet they don't have these same type of collision findings that you see with motor vehicle collisions. Why is that the case? When it's the speed that's involved, it's exponentially greater. And this is a good study that actually showed that the speed, the acceleration, deceleration, and the speed at which it happens look, it's milliseconds for the pedestrian accidents being hit or the falls, what happens in the brain, versus football players, it may take a lot slower. And I like to use this example, which has a higher risk of brain injury. You have a football player traveling 10 miles an hour, 260 pounds. They may be accelerating very nicely for what they do. Or you have a truck that's traveling at 20 miles an hour and 15,000 pounds. The speeds, the velocity, and the forces are significantly higher for these type of collisions. And in the brain, it causes something called viscoelastic tears. And this is a demonstration of what we talk about, because with the military, we'll see blast injuries with the brain where you have an explosion causing brain injury. But for the most part, for what we do, we're going to see a lot of direct impact injuries and acceleration, deceleration injuries. And sometimes you'll see a combination of both. But with contact injuries, so it hits the brain. And when it hits the brain, it actually winds up causing different injuries than the acceleration, deceleration injury. So the contact injuries are more frequently linked with epidural hematomas and contusions of the brain, whereas acceleration, deceleration forces are more frequently with subdural hematomas and diffuse axonal injuries. And this is a very important characteristic because these type of injuries are different mechanical injuries to the brain that are going to cause different secondary effects, okay? And so it is important to recognize that you don't have to hit your head to cause a concussion or a brain injury, but also the forces involved are linked to some of the primary tissue damage that may cascade into secondary damage. And this was a cool study that was done at UGA, go Dogs, and this was in 2003, and it compared motor vehicle collisions with sports injuries. And what they found is, and it was to their surprise actually, they found that actually motor vehicle collisions had a total number of symptoms that were greater than sports injuries. They also had worse long-term prognosis. So the ultimate thing was medical providers and individuals experiencing concussions should know that concussions are heterogeneous within and across various mechanisms, meaning that what goes on in the brain is the secondary effects are very similar between the two, but the conclusion showed that motor vehicle collisions have worse long-term prognosis. And this was back in 2023. And as I was telling Jen yesterday, I was updating my slides, and this was in the Journal of the American Medical Association, which is I think this paper is just fascinating. It talks about the 9 characteristics why people have long-term problems or cascade into secondary effects. And the thing I pulled out of this one, which is really, really interesting, again, this is in the Journal of the American Medical Association. If the mechanism of injury was related to a fall, vehicular collision, or abuse, the risk of having persistent symptoms was more than twice as high as compared to other mechanisms. So that's why this is called a silent epidemic, because a lot of times people may persist and they think, oh, they're crazy, they're difficult, it's not related, they're malingering, they're carrying on. And in reality, they're faking. They're not faking, they're trying to do things to make their life normal again. In fact, I would ask that before, Dr. Collin, how do you know they're not faking? I'm like, they are faking. They're faking being normal. They're really tore up inside. So, but they get classified as malingering, but in reality, they have a lot of serious mental health issues as well. Again, there's a lot more research that's been put out there. This is actually one put together by the government. So back in the 1970s, there was maybe 10 papers a year on brain injury. Now there's about 3,000 papers a year. So the awareness about brain injury is coming out leaps and bounds just because of the fact that there's a lot more studies and research. But this was put together by the National Academy of Sciences, Engineering, and Medicine, a collaboration with the U.S. military as well. And this is really a great document to have in your possession, but it talks about traumatic brain injury and the long-term prognosis. And in dealing patients with impairment ratings early on, I've been certified in doing impairment ratings since 2005. The first editions basically are like, yeah, brain injury, everybody gets better, don't worry about it. And it's now progressed into, wow, this is a more serious problem than we thought. And so they actually do a very good job of documenting what is the long-term loss with something with a brain injury. But in this document, they say not only is the characteristic of or classification of acute TBI as mild, moderate, and severe crude, it often promotes the bias that can limit care. Oh, it's only a mild brain injury, you should get better. Patients with mild brain injury often receive no follow-up care based on the assumption that they should have a spontaneous recovery, despite the growing realization that a subset of these patients will experience persistent symptoms and impairments after a mild traumatic brain injury. Now, this echoes what was said in that earlier paper I showed. Traumatic brain injury should not be treated as an isolated event, but as an evolving condition that may have lifelong effects. And that's sort of been my mission for the last 5 years, is create awareness about brain injury and some of the long-term effects, and also some of the best treatments. What's the best thing to do after a brain injury? And another study that was done in Johns Hopkins University. This finding is consistent with the body of growing research that conflicts with the previous understanding that a majority of patients recover quickly after mild traumatic brain injury. Okay, so Johns Hopkins, all these studies are showing, look, we thought that patients, it's spontaneous recovery, they're going to get better, when in reality, they find that there's actually some long-term problems that aren't properly documented or weren't properly documented. They're now becoming more enlightened. This is a great journal, the Journal of Neurotrauma. Traumatic brain injury remains a leading cause of disability across the lifespan. The majority of people with traumatic brain injury require minimal to no inpatient hospital care. You know what? They weren't in the hospital. You know, they should be fine. It wasn't that bad of a brain injury. Although I recently did a case where it was a 19-year-old hit by a dump truck, and she actually was in the hospital for 2 weeks with a brain injury, brain bleed. And they still said it wasn't. They said, "Oh, it should get better. You know, she's just carrying on." But in reality, she had a very, very significant brain bleed, brain injury. Outcomes from non-hospital TBI are variable, with persistent symptoms and disability occurring to 1/3 of patients. So this is saying this is a major lifelong problem, and up to 1/3 of patients who have brain injury are going to have ongoing problems. Now, it is also important to realize getting the diagnosis is right. If they have a brain injury, it's important to diagnose and get the proper care. But also, if they don't have one, it's a disservice to label a patient having a brain injury if they don't really have one. Again, this is one that was done. This is one of the first ones that have been done specifically on motor vehicle collisions. 1,700 motor vehicle collisions they looked at patients, and after a 2-year period, they still had pain. And so the more body sites that they were, areas of pain that they have, the less favorable the prognosis. So when patients have on my neck, my back, sensitivity to light, blurred vision, the more symptoms that they have, the worse the prognosis. And that usually means the worse the prognosis as far as the parts of the brain damaged. In some cases, we use DTI, and DTI long-term can show axoplasmic tears and injuries. And it's interesting because we've been able to show that the areas of the brain damage correlate with the patient's symptoms, which are really interesting. And the AMA Guides to Impairment Rating, they go over, permanent injuries. It's a gold standard, been used since the 1950s. And they talk about permanency. We don't expect them to get better. Typically with a brain injury, it's going to be about 1 year to 2 years that you would then call it and say, this is as good as we're going to get it. But also it's important because the AMA Guides recognize the fact that these conditions are not dynamic, but they're static, and they typically get worse over time. This is also common with post-traumatic arthritis. So we're going to flip through a couple studies right now, and I have about 10 minutes. We're going to go over what are the long-term consequences of brain injury. What does the epidemiology show? And this is one of the ones that came out, again, last year that was very, very significant and important to know, especially if you, your client, or your family member has a brain injury. This is, again, in the Journal of the American Medical Association, the periodical Neurology. Mild traumatic brain injury has been found to have a small but significant reduction in long-term survival. Okay, it causes you to live less time, and this is a course over 30 years. They found it causes a 2 times fold increase in long-term mortality when you have a head injury versus not having a head injury. So if you're a family member, if you have a brain injury and you say, wow, look, you have a reduced lifespan now because of this. Is that important to know? Yes, it's very important to know. But again, this is the Journal of the American Medical Association. It's not just some random journal. This is a journal, again, JAMA, Journal of the American Medical Association, and it was done over a 13-year period with veterans, 350,000 veterans, a 2 times increased risk of dementia. If someone's going to say to you, look, you had a brain injury, and this is considered a mild brain injury without loss of consciousness, and you have a 2 times increased risk of dementia. Is that important for you to know, to advocate? Yes, it is. It's important for the client to know, to maybe change lifestyles and focus on their health to make the brain function better. It's essential to know. Lost time from work. Oh, they're just, they just don't want to work. The study shows that 2 in 10 people after mild traumatic brain injury are still unable to work after 10 months. Okay, they're just carrying on. They have a problem. And even in the prisons, 80% of people in the prisons have had brain injuries, but they're untreated. some of these people aren't bad people. They've just had brain injury and weren't properly treated. So it's important to recognize and to dive in deep for these patients to give them the care they need, but also recognize that these brain injuries may not have the acute symptoms, the life-threatening acute symptoms, but long-term they have neurodegenerative changes that are important to know. It's also important sometimes with teens. So I'll see girls, particularly cheerleaders. Cheerleaders have a high risk of concussion, but also in falls, pedestrian accidents, and other types of collisions. You know, a teenager, particularly a female teenager, having a brain injury could change the entire system as far as hormonally is concerned. So there's also a lot of research going on that traumatic brain injury affects different people at different stages of their life. There's also a different genetic predisposition to patients who have brain injury. So some patients genetically may be at high risk of having problems, and there's a lot of testing being done now, which patients are at high risk versus patients may be at lower risk. Again, I was going over studies, put together studies for this presentation. This is one I love. It was a study basically of all the studies that have been done throughout the United States and the world about brain injury. And the conclusion was traumatic brain injury leads to an increased rate of dementia, including Alzheimer's disease. And, you know, I used this in the depot and they were like, oh, well, they must be small studies. I was like, well, this is a study of 3.2 million people. Here's another study of 3.6 million people. So they took records from socialized countries about brain injury and then followed up with them over time to see if they actually do have long-term consequences. And they found that it definitely increases the rate of dementia and other mental health problems. This was the Alzheimer's and Dementia Association. We found that head injury was associated with a 1.4 times increased risk of dementia over 25 years. You know, whether it be 1.5, 2%, any increased risk is too much if it's your brain that's being degenerated. Suicide. Unfortunately, you know, having young kids and, well, my kids now are in college and stuff, but they've had kids who actually had brain injuries and actually did commit suicide. You see this very commonly in veterans as well. I've seen this with some veterans that were patients that had brain injury and that they unfortunately took their life. So suicide is also a very realistic value to realize for these patients. This was one that was done with mild traumatic brain injury without intracranial bleeding. 56% of these patients still had symptoms 6 months after their injury. Stroke. You know, I just had a case last month about this, and, you know, the stroke was about 4 weeks afterwards, but you have an 86% increased risk of stroke after a brain injury, and this remains until about 4 months afterwards. So 86%. So what would typically happen is somebody would say, oh, they had a brain injury, they have a stroke 4 weeks later, and they say, well, that's not related because it happened 4 weeks later. Well, this is a great study to know that, hey, look, typically they're, you know, it could remain for many, many months. In fact, it doesn't get back to normal until 5 years post TBI. So the stroke risk is the highest the first 4 months, but it remains significantly higher than not having a brain injury for 5 years. And again, if this is your brain and you're having these long-term consequences, you know, typically in the past it hasn't been correlated, but it's important to know. This is a great one I like too, where it talks about autopsies. These are people who had brain injury, but yet they didn't have loss of consciousness, and, you know, they actually did autopsies, and they actually found that they showed neurodegenerative changes compared to someone who didn't have brain injury. So they didn't necessarily even have many symptoms. It just, as they got older, the brain started deteriorating compared to people who didn't have brain injury. And I know we're running low on time, so I'll run through these last ones. Dementia, this is another one from the Alzheimer's Association. And this was a really cool one because they took twins, and they actually found, is there a genetic predisposition for it? And they found that the twins who had a brain injury versus the twin who didn't have a brain injury, there's a 30% increased risk of dementia between the twins. And this is a pretty cool study because they can't just say, oh, they just normally were going to develop dementia. It's like, well, no, twins who didn't have brain injury versus twins that had brain injury that have the same genetic makeup, 30% increased risk of dementia. And as I talked before about seizures, epilepsy, you know, this is a very common thing that isn't necessarily associated with traumatic brain injury, but sometimes when you look back, you see that it is associated with it. The spontaneous risk of seizures is 1 in 6,800. And again, if they've had previous seizures, it makes difference that they may have a recurrence. But the risk of normally spontaneous seizure in people who don't normally have seizures is 1 in, say, 7,000. But after brain injury, it's 1 in 123,000. So it dramatically increases the risk of brain injury. Seizures does, or brain injury increases risk of seizures. So it's important to recognize that. And if it's been a year later, you're like, wow, is that seizure related? And it more likely is if they didn't have any pre-existing problems. And this is from the Epilepsy Foundation. It talks about how the rate of seizure doesn't normalize until about 10 to 15 years after the traumatic brain injury. In fact, doing DOT physicals, if you have seizures, they don't let you drive because of the fact that seizures can definitely come back again. So seizures are a very important thing that could be potentially dangerous to not only the person having the seizures, but people around them. And like I said, I did also want to point out that a lot of people in prison have brain injury, and some they just don't get treated. So it is important that these also cause mental health problems as well. Early on, Jen talked about how we do impairment ratings, disability exams, but also, we get in and talk about patients' pain. And these are two terms that I wanted to end it on today because I know we're running late, but we deal with pain, we deal with suffering. And a lot of times there's really what is pain? What is suffering? So the AMA and the International Association of Pain had this definition from 1972, and they revised it a couple years and only changed one word. But pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in such terms. And that's an important thing to say, is it individual to each patient. But also sufferings. A lot of patients' pain turns into suffering, particularly over time. It wears people down. It beats them down. And suffering is a severe, negative, complex, and dynamic experience in response to a perceived threat of an individual's integrity of itself or identity as a person. And for these patients, they're no longer the same person. I just did an impairment rating this morning of someone that broke their wrist, had plates put in. They're right-handed. They can't use the right hand anymore. And, it's changed their life. They're no longer the same person. Yes, they're not in a wheelchair. They're not going to die, but also they're no longer the same person as they once were. And that's where the impairment ratings, disability exams, causation determinations help to tell the story, to say, how are they different than they were before this injury? And I think that is it. There's one more slide, but I think we'll leave it at that because I know we're running pretty late. Is that quick enough?
We still have some time. No, that was great. We still have a few minutes. I'm always reminded that you have so much content that you inevitably always feel like you needed more time. We need to do this as a double, part 1, part 2. But I'm glad that we did record it, because each of those slides, I know you spent a lot of time putting together, and each one has an individual, multiple things to pull from. And I have questions, but I know Laura's ready to ask you a few, so we'll start with her, and then I'll check the chat box, and if we have time, I'll try to insert mine. Otherwise, I'll just have to get you offline.
Thank you, Jen. Thank you, Dr. Connolly. That was amazing about, learning so much about the bridging pain and neuropsychology. Couple of questions I have. Actually, I have several, but Jen, let us know on timing, okay? Doctor, from your perspective, what does an ideal collaboration look like between treating providers, attorneys, and medical funding partners to streamline patient access, reduce delays, and make the whole process more ethical and efficient?
Well, I think access to care is huge. Getting them to the right providers is huge. As that first or second slide showed, is that, even at the ER, oh, you didn't have a brain injury. And that's, that's something where there's a disconnect. So a lot of times ER doctors say, well, you may not have a brain injury, but what they really mean, you don't have a bleed and you're not going to die. So getting them proper care is essential. And even what is the proper care? And there's a whole seminar on that. But basically, that's the thing that the future will hold, is having providers that are well trained in what to do after brain injury and what not to do after the brain injury. In fact, the Brain Injury Association of America just put out a document that was a peer-reviewed document that what do you do after brain injury? In the past, rest, stay in a room, dark lights. That's the absolute wrong thing to do. So one, get them to providers that are well trained and versed in brain injury, what to do, what not to do. Time is essential, because if there's a gap, then that allows for the primary injury to turn into a secondary injury. Think about rust. Okay, if you have damage to a car and you wait, you say, well, before I fix it, before I put primer on it, I'm going to wait 3 months. Okay, the rust is already going to sit in. And actually, that's the benchmark for turning into persistent post-concussive symptoms is 3 months. So if you wait too long, the brain is going to start that cascade of secondary changes, and it's very, very difficult to change it. If they could get care within the first 2 weeks, that is game changing to their health. So early access to care. Number 2 is, working with providers that, understand brain injury. Number 3 is not just what now? A lot of times brain injuries, well, we don't know what we can do. Well, no, they need ongoing care, so giving access to care. A lot of patients with brain injury lose their jobs. A lot of patients have stress, financial, so access to funding is essential too to help them sustain their lives. Because the last thing you want to have is someone who, and I saw this yesterday, they had a brain injury, they haven't been able to work. I mean, and the stress from not being able to work, the financial stress has amplified the secondary changes in the brain and caused other problems. So giving them access to funding and talking to them. So I think attorneys need to stay in touch with their clients. How are you doing? Providers need to, how can I help you? So sit down with them, talk to them. Caring is an important part of TBI care.
Great answer. Thank you so much. Doctor, you mentioned that many mild TBIs are missed in the emergency room, and that follow-up is often inconsistent. In the first 14 days after a crash, what are the most important steps clinicians and attorneys should take to document symptoms and ensure patients don't fall through the cracks?
Well, I would say that document the American Academy of Rehabilitation Medicine, the symptoms checklist, and I could provide that to anyone, but basically even the CDC has some great protocols, but screen for them. Many times they think, oh, I'm just crazy or, whatever, but in reality, they had a brain injury, but, I see a lot of times sensitivity to light, blurred vision, irritability. For a lot of patients I do with the permanent impairment ratings, it's been years that they've had their brain injury. There's a high rate of divorce, of alcoholism. So screening, talking to the clients. The number one thing that I see with attorneys across the country is that they actually talk to the clients. Talk to the coworkers, the spouses. How's this affected their life? But many times, you talk to the spouse and it's a different story. So I would say for attorneys to also talk to the people around them. So I had one where they said, oh, they're fine. The client said they're fine. Patient said they're fine. But when you talk to the wife, they said, no, they're not fine. In fact, they walk around and they lose things. And in fact, they actually had a series of files because they were actually an insurance agent. And they actually put the files rather than the file cabinet because they're working from home. They actually put it in the freezer. So, they may think they're fine, but they're not fine. So talking to the client.
When a CT or MRI is negative, but symptoms persist, which clinical assessment, vestibular, cognitive, neuropsych, or advanced tests do you do or do you find most useful, and how do you explain their medical necessity to payers or the court?
Well, first of all, it's important to recognize that the brain is the most complicated structure in the universe. Okay, we have over 100 billion neurons. We have trillions of glial cells. It takes 25% of all the oxygen in the body and 20% of all the glucose. It's complicated, very complicated. So I like to say then, if that's the most complicated structure in the universe, the brain injury is the most complicated injury in the universe. And so there's not one fit for every patient. And that's why it's very difficult. You have to have providers that actually know what they're doing. So DTI is very, very helpful. CT can be very helpful. But a lot of times they say, well, we did the CT at the beginning, but it didn't show anything. Well, we do a CT a year later and it actually shows the brain starting to shrink due to the dementia and reduced blood flow. That's an important thing to know, but timing of the test can be different at different stages of the injury, but really it's a complicated thing that there's no one answer for everyone, but also it's something where the science is evolving. So it's really important to have providers that you could trust, that you would go to yourself to say, wow, this is the good care. But it is individual to each individual brain injury client because each patient's different.
And Jen, I know we're out of time. I was going before I continue with the questions, if we have time, if anybody else online has questions.
No direct questions, but we have thank yous for your time and your expertise. I know everyone's listening hard, and they probably have follow-up questions. I think if Dr. Colley can stick around, we have time for one more question, Laura, if you want to ask one last question.
Sure.
And the best part is that Dr. Connolly doesn't know it's coming, so it keeps him on his toes. None of this is pre-scripted, so go ahead and give him the hot seat.
Like being in a deposition.
Yeah.
Absolutely, yes. So, Doctor, your slides highlighted that a significant share of mild TBI patients have incomplete recovery at 6 months. What early warning signs predict prolonged symptoms, and what early interventions move the needle the most for outcomes?
Well, I'm glad you asked that. And that actually, if I go back to my slides, actually, that was the one study I cited actually goes over that, which was just released this October, and it's really, I think, one of the best TBI papers I've seen in a long time. And oh, here it is right here. So I hopefully you can see it. But 9 characteristics were significantly associated with persistent symptoms 30 days afterwards. So females, body elevation, elevated body mass index, mechanism of injury. So like I said, trauma, it was one of the things they found. Prior diagnosis of migraines or headaches, depression, anxiety, neurological deficits, the more symptoms they have, headaches, multiple scan intakes. So if they keep having, like, for instance, the need for CT scans, maybe there is a bleed, but it is something where this is a great paper that answers that question. And basically it says that these are the 9 characteristics that were found to have people who have more persistent symptoms. So there's a lot of research being done on it, but those are screening factors. And also when I read the paper, I agree with it that, typically in the patient population I see, these are the predictors, not only of patients who don't get better with chronic brain injury, but also with chronic pain as well. And so those are factors, and the study outlines it. And like I said, I'll give it to Jen to have everyone read, but it was just published about 2 weeks ago in the Journal of the American Medical Association. And it goes over the 9 different factors to look for patients who have traumatic brain injury. By identifying these factors and getting them the care they need, and for the providers to really even spend a little extra time with them to explain stuff, can reduce the secondary changes in the brain and give them a better chance to not develop the persistent symptoms.
Oh, that's fantastic. And we love fresh out of oven information. That's amazing. And before we let you go, Dr. Connolly, what is that quote behind you? It says, I can read half of it. It says, power that made the body. Can you read
Heals
the
the
whole
body.
quote?
Heals the body. So that's the thing that we want to try and help the patient become agency, to have be involved in their own care. So the power that made the body heals the body, but we want to help the body function better. And in fact, another study that came out about 2 weeks ago talked about patients with brain injury. They actually lose the ability of agency, and they get hopelessness. So many times they'll actually have a brain injury and they don't get follow-up care because it changes the way the brain is, and they get into like a depression. They almost just like isolate themselves. So that's also an important thing to recognize, that patients with brain injury need extra care, scheduling appointments, need extra care with follow-ups. So, a brain injury is a whole different animal, but in general, we try to help patients help the body heal itself. But also it's important to realize the patients with brain injury typically lose that motivation to help themselves, and they become helpless, and that causes the cascade of events. So that's why it's really important to be advocates and have the attorneys, have the providers realize, look, a brain injury is a different ballgame. We need to be a lot more in their face about getting care, but also a lot more involved with them because they need help. Patients with brain injury, they lose their appointments. I had one last week. They were supposed to be here on Thursday. They came on Wednesday, and we're like, oh, you came early. They're like, oh, well, I got the days mixed up. And so, of course, if they have a brain injury, they're going to have problems.
Thanks for watching this video. Your brain doesn't have a reset button, but it does have a roadmap, all things neuro and Neuro 360, for the data-driven truth about TBI and neuro wellness. No fluff, just the science you need to stay ahead. Hit subscribe. Knowledge is your best defense. And visit our website, neuro360care.com and allthingsneuro.com.